Good afternoon and good morning, depending on where you are. My name is Jose Leon. I am the Chief Medical Officer for the National Center for Health in Public Housing. We'd like to welcome all of you to our session number 4 on motivational interviewing and the empowerment and self-management of diabetes, the Pharmacist and Diabetes Care Learning Collaborative. It's such a great pleasure to have two great panelists for today's webinar. And before we get started, we have some information for all of you. If you are this activity for the first time, thank you for joining us. And the National Center for Health in Public Housing is very happy to have all of you attending this activity. This is a live activity. At this moment, all lines are muted. We are going to have a chat, we are going to have a Q&A session at the end of the webinar, and you can either use the chat box and type your question, or you can use the raise hand icon and your line will be unmuted. Next slide. So before we get started again, there is a handout that you can download from GoToWebinar. If you go to the handouts section on your control panel, you will see that there is a handout that you can download. And at the end of the webinar, we are going to have a survey. And so if you take some time and complete the survey, your information and your response and your feedback is really important. So the National Center is funded by HRSA to provide training and technical assistance to community health centers, especially to the health centers located in or immediately accessible to public housing. Next slide. There are around 2.2 million people living in public housing, and there are a couple of issues affecting public housing residents, which are really important to discuss at this moment. One of them is that 38% of them are disabled, 43% are African American, 25% are Hispanic, 52% are white. 38% of those living in public housing are children under the age of 15, and around 80% of them are below the federal poverty line. 55% of them have less than a high school diploma. Next slide. So since 2016, NTAPs have been working on diabetes. Diabetes is a health HRSA priority, as well as childhood obesity, emergency preparedness, and for us, the National Center for Health in Public Housing, smoking cessation has been a big priority since the HUD rule banning smoking in public housing. Next slide. It's important to notice that 17.6% of those living in public housing, or at least receiving HUD-assisted housing, are diabetic, and around 13% of them have COPD, and around 16.3% of them have asthma. I would like to highlight as well the overweight or obese part, when 71% of those living in public housing are either overweight or obese, which is really important when you discuss diabetes. As I mentioned as well, 34% of those living in public housing are current smokers. Next slide. So I would like to, it is my pleasure to introduce Frank Italy. Frank has been collaborating with the National Center for Health and Public Housing for many years, and Frank Vitali is the National Director of the Pharmacy Partnership for Tobacco Cessation. He has worked in the smoking cessation field since 1987, designing cessation programs and educating over 20,000 health professionals in how to help patients stop tobacco use, and counseling nearly 10,000 patients to quit. He received a BA in Liberal Arts from St. Vincent College in 1974 and a master's degree in psychology from Duquesne University in 1988. He entered the field as a health educator, then as a clinic coordinator for the Lung Health Study, researching the differential effects of smoking cessation and inhaled medication on the prevention of COPD in identified high-risk individuals. He has run numerous groups for the I Quit project of the Smoking Research Group at the University of Pittsburgh, as well as designed the intervention for some of these programs. So without further ado, I will turn it over to Frank.
Thank you. Good afternoon from Pittsburgh. It's actually nice and sunny here today, which is unusual. So today I've been asked to talk about something called motivational interviewing. This is an extremely expansive topic, and if you go to a training for motivational interviewing, it usually takes a couple days and maybe even 3 or 4 days. So there's a lot involved here. So what I'm giving you today is just a very, very basic review of 1 or 2 of the basic concepts involved with this. Then Terry, who's following me, she's going to go into a little more detail and look at it from a slightly different perspective. Now, what we're talking about here, first of all, I want to tell you what we're not talking about. Motivational interviewing is not doing counseling, so don't get scared. Even though my background is in psych, this has nothing to do with therapy or anything like that. You go to the next slide, you'll see that this is basically just a way of talking to patients that is essentially different from what we were taught in school, especially pharmacists. Pharmacists have been taught to tell people, give them information and tell them things, and then expect the patient to do it. And that's perfectly fine when you're prescribing medication, when you're filling prescriptions or teaching people how to take a medication. You have to do that. But this doesn't necessarily work with behavior change. So even though my area is smoking cessation, what I'm about to talk to you about has to do with all kinds of behavior change. Even, hopefully you'll see, in getting people to take medication on a regular basis. So what happens is, if you use this same approach about just telling people what to do when you're looking at behavioral change, you end up, even with your best intentions, you end up kind of chastising the person, hollering at them, wagging your finger at them to get them to do something. And in most cases, when you do that, who do you become? So think about that for a moment. You end up becoming their mother, which I know you don't want to take that role on. And if you become their mother, how do most patients react? Well, they resist, just like we do with our mother when we're kids. So this has nothing to do with us directing, telling patients what to do. Rather, we come at this from the perspective that the patient in themselves knows what they need to do. We just need to help them get to the point where they will take action. So next slide. So what we're talking about here is guiding the patient. You want to provide them with such powerful information and ask them such provocative questions that they tell you they want to change, rather than us telling them they have to change. Now think about that for a moment. This is very different, but it's very doable. So what I'm going to give you is a couple key points here. I've talked to trainers who are involved in MI and made a career of this, and what I'm about to give you are some of the real key points to help you do this. So again, you want to give patients such powerful information and ask them provocative questions so that they tell us they want to make a change rather than us telling them they have to do it. The bottom line is, and you'll see this on a slide in a moment, behavior change generally only happens if it comes from an internal source. We do respond to people nagging sometimes, but we just do it just to get them to get off our backs. Real behavior change, lasting behavior change only comes when it's internal. So the whole point of all of this is helping your patient find the motivation to make this behavior change, whether it's to eat better, take insulin, quit smoking, exercise. It's all basically the same concepts. Next slide. So as I just said, and I really do want you to avoid this whole idea of wagging your finger at patients, because it doesn't work, and you know that. Next slide. And in conjunction with that, I want you to stop using the word stop, because again, that is it's you telling the person what to do rather than the other way around. I've worked in smoking cessation for 33 years now, and I've never, ever told a patient to stop smoking. I've never used those words because I know that that's not really why somebody will do it. Next slide. So what are the benefits here? Well, we hear this all the time. We get so frustrated and so angry and upset with people who won't do what they're supposed to do. Well, this time it takes you out of that realm and helps you step away, as I said, from that role of being a parent. And what it does, and what's so great, is that it creates collaboration between you and the patient. And I think that's probably it's a much more comfortable place for you to be, and it certainly is a much more comfortable place for your patient to be. Next slide. So the question here is then, how do you do this? How do you create change? Next slide. So first of all, you want to understand that people are ambivalent. That's not a bad thing. Getting stuck there is what is problematic. We are all ambivalent about any change we make. We very rarely go into just all gung-ho and saying that I'm ready, I'm just going to do this, bing, bang, boom. Also, I want you to, the other key concept here is to view change as a learning process. Very rarely, again, do we just go from point A to point D in a straight line. Relapse is a natural part of this process. Now, that doesn't mean you want to encourage it, but you want to understand that if somebody relapses back to whatever the other behavior was, you use that as a learning process. The thing you want to ask the patient there is, what did you learn about yourself that we can now use to make the change permanent? And then the whole rest of what I'll be talking about for the next 15, 20 minutes is how to elicit change talk. So again, you want to be asking questions that are going to get the patient, that lead the patient, help the patient come to the point where they're going to tell you they want to make this change rather than us telling them they need to. Next slide. So the goal of change talk, again, there's that word collaborate, is you want them to understand their own motivation for making the change and to view the change as more enticing than the status quo. Many, many times people are afraid of change, they're scared of change, they don't think they can change. We'll talk about that in a moment. So we've got to help them understand that the change is better, is more interesting, is more exciting than what they're doing. And then we also have to help them understand that they can do it. Many people won't change because they don't think they can, mainly because I think they've been told most of their lives that they can't. So that's all wrapped up in this. Okay, next slide. To reiterate, change is more likely to occur when the idea comes from the individual, not from you. I think you all know this, you just have to be aware of it when you're talking to patients. Next slide. So why don't people change? Why are they stuck in whatever it is, even though it's bad for them, even though we know smoking's bad, being overweight, da-da-da-da. Well, in a sense, they're comfortable with it because it has value to them. Now, I know that sounds strange, but when I work with people about quitting smoking, I always start from, what's the point of doing this? And there usually is. They usually have some really good reason in their own thinking. It's not necessarily really a good reason, but in their own thinking, there's a value to it. There's an importance. And as I just said, they're afraid to change or they don't think they can do it. So on the next slide, why do people change? So if you go to the next slide, please. The new has more importance or value than the old, and they're uncomfortable with their current situation. They also change because they are comfortable with the idea of doing it, and they feel they have the skills and knowledge to be able to do it. So that's really all, we're focusing on all of this when we're providing information and asking these questions that I'll be going through in a bit. Next slide. Now, I just want you to realize that change usually does not occur like bang, out of the blue, but it is a process that occurs over time, not a discrete event. Generally, now I have worked with patients who they have the heart attack and they realize it's because of their smoking and then they quit the next day. It does happen, I'm not denying it, but generally it's a process. Next slide. We're not going to go into detail here because we don't have time, but there is a model. Prochaska and DiClemente have looked at not why do people change, but how do people change? And this is the process. They're not thinking about change at all. Then they start to contemplate it. They start to think about it. Then something happens and they take action. Then we hope they stay, the change stays, but we do know that little slips happen here and there, and then relapse occurs in many, many cases. And then they have to go back through the process. So I threw this in because I want you to realize again that this takes time. It's not something that generally happens out of the blue. Next slide. I think you have to hit the next key there. So our goal here is to create change talk through motivational interviewing. So the next bit of slides, we'll talk about what the specifics are and how to do this. So first of all, you want to ask permission. I think the most important thing you can learn here, and what the experts have told me, is to start to use open-ended questions. So we'll talk about that. Listen reflectively, give feedback, and then roll with resistance and ambivalence. So these 5 things I'm going to go into a little more detail on the next 5, 6 slides. All right, so this may sound weird or sound, okay, why should I do this? But again, this is being collaborative. So do you mind if we discuss this today? Can I tell you what my concerns are? Is it okay to talk about whatever? If you do this, you're more likely to get the person to agree to have a conversation with you than if you just barrel in and start telling them stuff. So in all of these slides, I have suggested language. By no means do I want you to copy the exact words on these slides. Look at it, make it your own, make it feel real to you. So you ask permission, then on the next slide, you want to ask open-ended questions. I think if you take one thing away from this talk, this is it. Asking open-ended questions engenders conversations with your patients because there really is no way for them to answer them without having a conversation. So open-ended questions are questions that do not invite short or one-word answers. Now, generally, if I'm doing this live, I would ask the audience to tell me what 2 words do most open-ended questions begin with. But since you can't see me and I can't see you and I can't hear you, I'm just going to tell you. So on the next slide, you will see that most open-ended questions begin with what or how. So how would you feel if you ended up in a hospital room because of a stroke and weren't able to move for a whole week because of your smoking? So that's not hollering at the person and making them feel guilty, but it's asking them a legitimate question. What would your life be like if you were confined to an oxygen tank? What would your life be like if you lost a leg because you didn't do proper diabetes care? Yeah, so those kind of things, although it may sound like it's laying guilt on a person, it's not. It's just asking a simple question. Now, what's wrong with the word why? Well, again, no matter how good our intentions are, the word why in the English language in this country pretty much implies that you are accusing somebody of something. You know, it's laced with all kinds of emotion. So I really stay away from that word as much as possible. You can ask the same thing using the words what or how. Okay, next slide. So here are some examples. I'm not going to read them. You know, you'll get the slides after this so you can look at it. These are just some examples of questions you can ask. Next slide. So if you do all of this and the person still says, well, I'm not ready to go on that diet, I'm not going to eat that way, then this is probably one of the most powerful questions you can ask. What would have to happen to you for you to consider fill in the blank? Now think about that. What would have to happen to you for you to consider? So with many of my smoking patients, they say, well, I have to get lung cancer, thinking incorrectly that, you know, there's just some pill you can take and the lung cancer will magically go away. Then when you hear something like that, then that opens the door for you to educate, to provide the information. Okay, here's what happens when you get lung cancer. Here's your chances of recovery, blah, blah, blah. Same thing with diabetes. You know, if somebody gives you a smart aleck answer and says, well, I have to lose a leg or, you know, whatever, then at least you have some idea of how they're thinking. Can you see how this is better than just saying to somebody, well, don't you know smoking's bad for you? Don't you know you should be following a diet? Because all they're going to do is say yes. And that doesn't, so you get that, that's not a question, that's not a conversation. That's just a yes, you know, a question and an answer. You want to engender conversation here. Next slide. Okay, so there are some other ways, some techniques I'll give you here on these next couple slides to help you do that. So the first thing is called the importance ruler. So how important would you say it is for you to lose weight? So then I know you've seen this. You know, 0 to 10, not important or extremely important. So that again gives you some information about that you can discuss. Next slide is the confidence ruler. Now this one I like, so go to the next slide. So if you decided to begin an exercise program now, or quit smoking or go on a diet, how confident are you that you can do it? So let's say the person says 6. I don't want you to go in this direction. I don't want you to say, oh, well, yeah, you know what? I really think you're a 9, you know, trying to boost their confidence. There's a better way to do it. What I want you to say is, oh, really? You think you're a 6? You know, from our conversation, I would only guess you're a 3. So what happens if you do that? Well, the person, generally speaking, most of the time, and this usually works, is going to say, what? What do you mean I'm a 3? I'm really a 6. I really want to do this. So by going lower, you are in a sense encouraging them, nudging them to really say they are interested in making the change and actually verbalizing that. Again, you want the words to come out of their mouth, not yours. Okay, next slide. Now, here is a nice little trick. I really like this. If somebody is sitting there saying, I just can't do this, I can't, you know, it's not going to happen, blah, 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 blah. Ask them this question. What accomplishment are you most proud of? So they may say, well, I paid my way through school, or I, you know, climbed a mountain by myself, or I raised 3 kids, whatever. No matter what they say, your next statement is, well, you know what? If you can do that, you can make the behavior change that we're talking about. I worked at the pharmacy school at the University of Pittsburgh for years, and in the early in the 2000s, we had a student, a woman, by the way, who was deployed to Iraq for a year or so. So they held her position in pharmacy school. She came back and she was smoking. And the dean, had a talk with her about getting her reoriented and getting her set up and getting her back into classes. And one of the things she said to her was, as a dean and personally, I really don't feel it's appropriate for a pharmacist to smoke. So why don't you go down and talk to Frank? So she came to my office, and the conversation, was very nice, except she kept saying, I can't do this. There's too much going on, blah, blah, blah. So I asked her, what did you do when you were deployed? What was your position? And she said that she was one of those individuals who was finding the buried mines and exploding them. So I looked at her after she said that, and I said, Karen, come on. If you could do that, you could quit smoking. And when we were kids, that little light bulb we see in the cartoons go above somebody's head, I could just see her eyes widened. And she looked at me and she says, wow, you're absolutely right. This will be a piece of cake compared to that. So this can be a very powerful question, a very powerful interaction. I don't mean to imply that it's going to be the magic pill and everybody's going to instantly change, but this can be a very, very powerful, very simple, but powerful way of interacting with the patient. Okay, next slide. So another way to get at this is to look at what priorities and goals are in a person's life. So how is keeping the behavior that you have going to prevent you from achieving those goals? How important is it to achieve those goals? Now, if you're working with somebody for a long time and you really know them, you may go into this core values. How does a healthy lifestyle fit into your belief system? Every religion on this planet teaches in some way, shape, or form that it's important to take care of our bodies, that our bodies are our temples. So again, if you feel comfortable with this, then you can approach it that way. The last question, what role does smoking play in your life? That can be a real interesting way of approaching this, because in many respects, some of these behaviors link people to other behaviors. I've had people say, well, if I didn't smoke, I would never see my friends. So again, that's not really true, and there are ways around that for sure, but if that's the barrier, then you're finding it out when you ask this type of question. Okay, next slide. Elaborate. Again, this may seem pretty obvious, but we may not think about it when we are talking to patients. So the elaborating really gets into the nitty-gritty and helps you get a better understanding. Again, you want to get as much information and be as clear as you possibly can on what's going on with this particular patient. Next slide. Another way to do this is to kind of use this imaginary stuff. What do you imagine your life would be like in the next 2 years if you didn't do, or if you did do? Or if you did change right now, so if you quit smoking, if you went on the diet, if you got your diabetes under control, how would things be different in the next couple of years? Okay, next slide. So those are different types of questions that you can ask. And again, don't just read them out verbatim to somebody, but make them your own. Look at them and make them as, you put them in your own words. So listening reflectively is very helpful here. It's using the patient's own words when you respond to them. So, if the person says, I'm really scared to quit smoking, or I'm really scared of changing my diet, I hear that you're saying the idea of changing is very scary. That links you to the patient. So try to use their words, their concepts as much as you possibly can. Next slide. The fourth thing we want to talk about here is summarizing feedback. So I always leave people with a little bit of summary. You can write this down. You can just say, okay, here's what we've talked about. The next steps you said you were going to take. It always kind of leaves them with not literally homework, but at least something to think about, or hopefully something to do. So always end your conversation with some kind of summary. Next slide. Excuse me. So again, if somebody's being ambivalent, you really want to get at the core of this. And I'm going to give you a little tool on the next slide that'll help you get to that. So you don't want to be thrown by the ambivalence. You want to help them uncover why they don't want to change and why they do want to change, and then help them move on from that. Next slide. So this is a natural part of the process, as I've said a couple of times. The problem is getting stuck there. So you want to go to the next slide, and we'll look at how to get people out of that. I know you've all seen this before. It's pretty standard tool that we use in many different situations, but just make one of these decisional balance sheets. I find it interesting when I work with smokers is that in their head, they think they have 5,000 reasons to continue to smoke, and they can't come up with one reason to quit. But when they actually write it down, they realize that there really aren't any really good reasons to continue, and there's many good reasons to stop. Okay, next slide, please. So the whole point of all of this is to get the patient to be able to articulate a clear internal reason for doing whatever it is that we are hoping that they do. It can be health, money, family, anything is a good reason to make the change. It's just we have to help them understand it. I had a woman who was in her late 70s, came into me one day and frantically, Frank, I have to quit smoking right now. I have to do it today. And I said, Mary, hold on, what's going on? You don't understand. I have to do this right now. I said, all right, take a deep breath. You've been smoking for 50 years. What happened today that you had to do it? You have to do it immediately. And before she answered, I said, oh, I was right across the street from all these doctors' offices. And I said, oh, were you just at your doctor's? Did you just get some bad news about your health? And she said, no. This has absolutely nothing to do with me. It's poor little Fifi. Now, who's Fifi? Fifi was her dog who had been diagnosed with COPD because mommy had been smoking around her all these years. Now, that is very real. That can happen to dogs, cats, birds. So I'm sure some of you on this call are kind of chuckling to yourself, and I have to admit I did that internally, but I looked at her and I said, you know what, Mary, that's a fantastic reason to quit. As long as it's not hurting the person, whatever the rationale is, make it real for that person. And you know what? Once she understood that and once she articulated that, then she did it. Next slide. You can also be very supportive and hear through this. So you really do want to believe that every single patient you deal with can change. So that is a very important concept here. Next slide. And then my final reminders here, again, you can't make anybody change. The more you push, the more they'll resist. Just in a sense, think of what happens when you do this with kids. Rather help the patient want to change by increasing their displeasure with what the current behavior is and decreasing the fear of the new. In the end, you want to get the patient to present the reasons for the change out of their own mouth and to articulate a very strong, clear-cut internal motivation for wanting to do it. Next slide. So this is my contact information. If you have any questions about any of this, please feel free to contact me. Again, if you really want to go into this in depth, go to the next slide, please. These are the two references. Miller and Wolnick are the daddies of motivational interviewing. These are two books that you could get that are very well written in the sense that they are from the perspective of how do I put this into practice. And again, this isn't something you have to change your whole practice for. If you can just start asking open-ended questions, you're going to see that that's going to change the whole tenor of your conversations with patients and hopefully lead them to make the desired changes. Okay, thank you very much. We will have some questions and answers toward the end of the session. I'm going to turn this over to Terry.
Thank you, Frank. Thank you for your great presentation. And I am a dog lover, so I love the Fifi story. Next, we are going to hear from Teresita Lawson. She's a bilingual bicultural registered pharmacist licensed in New Jersey. Her role as clinical pharmacist for Suffolk Health Center included implementation of and continued quality improvement initiatives for the clinical pharmacy services program at Suffolk Health Center. Teresita has extensive experience in patient counseling and medication therapy management. Her role in Suffolk Health Center centered around direct patient care, patient education, and lifestyle modifications, adherence monitoring, identification of potential medication-related problems and adverse events, and provider education as well as medication therapy management. Teresita was an integral part of the Patient Safety and Clinical Pharmacy Services Collaborative, which has now graduated to the Alliance of Integrated Medication Management Collaborative, a national collaborative dedicated to advocating for pharmacists as members of the healthcare team through their expertise in patient safety, medication therapy management, and patient self-management education. Teresita is now actively consulting in the pharmaceutical industry and volunteer her time in helping to educate patients with diabetes live productive and full lives by overcoming barriers to care. Good afternoon, Terry.
Thank you, Dr. Leon, and thank you all for attending this series. Next slide. We'll be discussing motivational interviewing. I'm going to show you a video, and we're going to talk about what could have been done better. We're going to talk about the opportunities for pharmacists to relieve the burden, primarily in underserved and health professional shortage areas. And we're going to do an overview and takeaways on obesity management, management of our senior population, and some final thoughts on patient-centered, person-centered approach. Next slide, please. You could start the video.
Peter, we have no sound. Very sorry for the glitch. So let's see whether we can try it again.
Fisher, it's great seeing you. Thank you for coming to Diabetes Clinic today. My name is Mark Smith. I'm a pharmacist. I work with.
Is that better?
Yeah, it's working. So you can replay it.
Dr. Fan, we run the Diabetes Clinic, and we basically serve to educate our patients so they can better manage their diabetes. And looking at your chart, I see that you're a pre-diabetic. So what we're going to do now is kind of focus on nutrition, mostly diet and exercise. Okay.
Dr. Fan, or the nutritionist, I already know what you're going to tell me. So can I leave?
Okay. That's fine. I'm glad you had the opportunity to talk with the nutritionist. She's a very nice lady. She has very valuable information. Do you mind telling me some of the things that she discussed with you?
The same stuff you're going to tell me?
Okay. Well, I will show you what I normally go through with my patients, and then you can let me know if there's any information that you covered with the nutritionist, or if any of the material is new to you, then that would be great as well. Basically, we feel that going over the nutrition aspect of diabetes and pre-diabetes is so important. There's so much that we can do without taking medications, and we've seen many patients benefit from making just minor changes to their diet that have greatly impacted their health in a very positive way. So to start off, I'm just going to ask you a few questions about what you need to get a better picture of your diet. So first, what did you have for breakfast?
A couple of eggs, bacon, biscuits, grits.
Okay, all right. And then what about lunch?
Turkey sandwich and some chips.
Okay, turkey sandwich and chips. And then for dinner?
Spaghetti, salad, and bread.
Okay, spaghetti, salad, and bread. Okay, so tell me then, what about any snacking that you do throughout the day, like any snacks or anything like that?
I don't really snack, but sometimes ice cream after dinner, maybe fruit in between meals, but not very often.
Okay. And also, what kind of beverages and things that you drink? What are some of the things that you drink throughout your day?
I'm constantly really hydrated, so I'm thirsty, so I drink sweet tea all day long.
Okay. Well, thanks for sharing that bit of information with me, Ms. Fisher. This kind of gives us a better idea of what you eat throughout the day. So now I'm going to give you some information about nutrition. Okay.
Okay. I already know what you're gonna say. I need to eat less. I've heard it all before. It doesn't work for me, so
Okay. All right. So that's fine, Ms. Fisher. But just kind of bear with me. So what I gather from you thus far is that you know already and you're fully aware of the things that you need to do in order to live a healthy lifestyle and take care of yourself. However, you seem to find it difficult and you don't think that it works for you. That's kind of the picture that I'm getting. So explain to me, what are some of the barriers that you feel exist that prevent you from eating healthy and losing weight?
it's mostly the money. It's expensive to buy foods that are healthy, and I just can't afford it consistently. I also like food that tastes good. Unhealthy stuff doesn't taste good, and I just don't want it. And also, my kids want the good tasting food. They wouldn't even eat it if I made healthy food.
Okay, then. I understand completely that finances can be a potential issue and an issue, especially when it comes to eating healthy. More importantly, picking out the right healthy foods for your kids and also to have good taste is also a priority to you. So tell me about, we're going to switch and transition from diet and talk about exercise. Tell me about your normal exercise routine.
Honestly, I don't really have one. I haven't exercised in years. I just don't feel like it.
Okay.
I don't have the money to join a gym.
Okay. And then what are some of the barriers you believe that prevent you from exercising on a regular basis?
Kids, they take a lot of time and money. Like I said, gym memberships there's several close to my home, but they're too expensive for me to get. And I just don't have enough time. The kids take a lot of the day and then work.
Okay. All right. Then what ultimate benefits, let's talk about benefits. What benefits do you feel that you can ultimately gain by seeking out more nutritious foods and incorporating exercise into a daily regimen and then overall losing weight? What do you think would be the benefits of doing all that?
I mean, I guess it's good for you. Dr. Van always gets mad at me and says I'm not healthy and always talks about my weight. Maybe.
Yes. Well, and then those things are exactly correct. What I would like to do, Ms. Fisher, I know that you're pressed for time. I'm not going to take too much of your time, but I would like to schedule you in and basically sit down with you and kind of go over some.
For the interest of time, we could stop the video at this point and go to the next slide. Okay, so what could he have done better? So what we have here is a patient who's definitely displaying ambivalence. So we have to roll with the resistance, and he did. But I believe that he could have done a better job at identifying what the patient already knows from her encounter with the nutritionist. So tell me more about it. He did ask that question, but I think that if you put it together with encouragement, it's great that you met with the nutritionist. Tell me more about what was covered. Instead of going into what a nice person the nutritionist is, that would give us more information on what the patient already knows. Identifying what the patient is motivated by is also important, as Frank pointed out. It's about the patient. So what in particular impacted her during that encounter? And then identify what the barriers are. He did identify those. What information do you feel may be difficult to incorporate? And these are the barriers that moving forward we'll have to address with this patient. Next slide. He did summarize. It's important to summarize. You can summarize throughout the conversation as well as at the end of the conversation, but it's very important to acknowledge what information the patient is giving you in order to identify those barriers, and more importantly, identify the solutions that you may have in your arsenal that is achievable for that patient. Next slide. The ruler method, as Frank pointed out, is a very, very good tool to use to gauge how important it is to the patient, what is her confidence level in incorporating whatever it is that is achievable for her, and what will work for the patient, and identify again what solutions you can offer for her by asking what her thoughts are on how we can improve her level of confidence. Or you may use the other tactic of going, I think instead of a 6, you're a 3. That's another way of invoking more encouragement in your patient. Next slide. He went into a little bit of lecturing, a little bit of being the parent role. That's not the right way to go. It's not about what we think, it's about eliciting change for her and tying into what motivates her. So what benefits do you think you may gain from the incorporation of whatever it is? And you want to reinforce, this gives you the opportunity to reinforce those benefits with important information and education that you could give the patient during the conversation. Next slide. And you want to partner and collaborate. So how do you think we can work together? I find it a very good way to see where the patient is and how we can help them. And you also want to summarize at the end and congratulate them for their willingness to come in and talk about it. And you also want to set some goals at this point. Perhaps give them some homework with the balance sheet, pros and cons, and think about what would help her if she lost weight as opposed to not, and schedule your follow-up patient. Next slide. So some takeaways with respect to what we've talked about up until this point is, what are pharmacists doing already? We're already filling the gaps in medically underserved areas and health professional shortage areas. More work needs to be done, but there's not a town in the United States that does not have a pharmacy. So we are the most accessible. We're already doing health and wellness visits and preventive services. With the unfortunate pandemic that we've been under with COVID, more advances have been made in the services that pharmacists are providing. We're doing chronic disease management as well, but most importantly, it's in between follow-ups with the primary care physician, which gives us a unique opportunity to intervene where necessary and alert the primary care team that this is happening with the patient in order to make that intervention. We're doing comprehensive medication management already. This is something I dreamed about back in the 80s when I graduated pharmacy, and it was not in existence back then. And we're doing patient education and counseling. Next slide, please. So what needs to happen? This is old news, but we do need legislation. As I talked about in my previous presentations, we do have many bills out there. The one directly tied to medically underserved areas is 592 and 109 in the Senate. It is bipartisan. It is looking to change the Social Security Act to add pharmacists as recognized healthcare providers. And there are changes in the air. In 2012, the Centers of Medicare and Medicaid Services broadened the concept of medical staff in order to include other healthcare professionals that are necessary in the interdisciplinary care of our patients. In 2014, CMS told physicians that pharmacist services can be billed incident to, and encouragement from our pharmaceutical organizations. You have to look and see what bills are out there that promote and addresses the lack of provider status for pharmacists, and become boisterous. Contact your legislators. Next slide, please. What needs to happen as well is practice models need to change. One of the most common points that pharmacists pointed out are time constraints. In both studies that I brought forth to you, they complain most about not having the time to put these programs in check. There is an interesting article in Pharmacy Times called Tech Check Tech Programs, what the pharmacist needs to know. This is a technique that has freed up pharmacist time in Iowa and several other states across the country, where through education and training and lifting of some legal restrictions, technicians are actually driving and managing the dispensing function, thereby freeing up the pharmacist's time to provide the much needed clinical patient services that we need to provide. Certainly, we have to look at re-engineering our workflow. We need to look at what resources we can put in there. And we can also look at incorporating technologies, which is also happening across the board and across the nation. Utilization of robotics. We definitely need access to health information technology. And now, even more important with the COVID pandemic, is putting in some telehealth services. Optimizing medication synchronization services, that has also proved to improve workflow, and it also has shown to free up pharmacist time. We definitely need to remodel the pharmacies. If you walk into a pharmacy today, I'm sorry, but that little space, that little booth that they have just doesn't do it for me as far as privacy. And I can just imagine a patient trying to speak about their weight must feel in that ridiculous little space they give. And performance and quality measures definitely need to be directly tied to improving patient outcomes. I've never thought that a patient picking up a prescription means that they're adherent. It only means that they picked up the medication. And it certainly does not tie into a patient's outcome. Next slide, please. Our role in obesity management, again, is screening, education, management, and support. It's important to let our patients know, especially through motivational interviewing, the benefits of weight loss. It can delay the progression of diabetes. It can improve their mobility, their physical and sexual function. It can improve their quality of life. Modest and sustained weight loss can also mean a reduction of glucose-lowering medications. And greater weight loss equals greater benefits for the patient. So reductions in blood pressure, cholesterol, and it may even mean achievement of glycemic goals in the absence of these glucose-lowering agents in some patients. Next slide. As far as managing the medications in weight management, the most important things that we need to look at is what regimen are we selecting for that patient. We need to minimize, if we can, as far as we're individualizing that target, that we select medications that will least affect weight gain. And always important that they're just adjuncts. There is no magic bullet to weight loss. It needs to be an adjunctive piece of the program, and I'm going to get into a little bit more about that in the next slides. Monitor all weight loss medications for at least 3 months for safety and intolerances. And very, very important is that any patient with diabetes that's living with diabetes and is now looking to lose weight, has entered a program, is on weight management medications. It's very important to monitor them for hypoglycemia and change their regimens accordingly. Next slide. So these are the parts of the program that are necessary to include. You need to include some lifestyle counseling. You need to consider some stress management for your patients, whether that's some meditation techniques that you can teach, mindfulness, ongoing support, whether that be through telehealth online or through group discussions. Sustainable weight loss goals should be done collaboratively with the patient. 1 to 2 pounds per week is an acceptable goal and reasonable if it's achievable for them, remember. And planning for the future. How are we going to keep that weight off? How are we going to help them keep that weight off and maybe even garner health benefits from further weight loss? Next slide. And ahead of provider status, I would suggest that you design the program against the CMS guidelines. Of course, it includes screening for obesity, nutritional assessment, and counseling. As far as the counseling, it should be intensive behavioral counseling to promote that sustained weight loss, and should also include diet and exercise. And we all know about the 5 A's. This is very integral to the motivational interviewing process, where we assess, advise, agree, assist, and arrange. As far as arranging, I can't tell you how important it is as pharmacists for us to tap into our community resources to make sure what resources we have for our patients so that we can offer them the solutions that they need and that will help them. Next slide. Our seniors. The most important thing here is to be aware that they are the most prevalent patient population with diabetes. They have the most prevalence. They have the highest complexity and vulnerabilities. They're more likely to have higher rates of premature death and functional disability, comorbidities, higher rates of complications like amputations, visual and hearing impairments, end stage kidney disease. They're more likely to have challenges in self-managing and improving their quality of life. And because of the geriatric syndromes that they are facing, like polypharmacy that we're very familiar with, decline in activities of daily living and depression, they have much higher likeliness of having these issues, and they have much higher rates of ER and hospitalizations, not just due to hypoglycemia, but also due to hyperglycemia. Next slide. Screening for cognitive impairment is really crucial in this patient population and should be done at every annual well visit. We are conducting annual well visits as pharmacists. I highly recommend you use the mini-cog that I suggested in my presentation. Hypoglycemia, it's been tied to a cognitive decline, higher rates of it in these individuals that have impairments in this arena. So we should be looking at those glycemic targets very closely and adjusting those pharmacologic regimens accordingly. Recognize those red flags. When you see a patient that's having issues with self-care, that may be having new issues with calculating insulin doses and skip medication doses, and that may be an individual that may need to be screened and maybe even referred for further evaluation. Also recognize that in this population, it's likely also that they have a higher rate of hypoglycemia unawareness. I know many of my patients did in this population, so be very aware of that. Screening for falls and risk of falls is also something that should be conducted at least annually in our annual well visits. And be aware that, and I'm sure as pharmacists you are, many of the medications that these patients are on can cause dizziness, can cause sedation, can cause imbalance, syncope, as the patient case that I presented to you, where maybe her lisinopril dose needed to be reduced. Advise your patients to eat well and have regular exercise within their limits, but any amount of exercise that they can do is going to be beneficial. Next slide. Medication reviews ongoing to measure the indications for each medication adherence, and ongoing assessment of barriers in this population is very important. Our focus and strategy is de-intensification or simplification of complex regimens. We want to reduce that risk of hypoglycemia and side effects. De-intensification or simplification of insulin regimens, consider it if you're seeing a lot of hypoglycemia going on, if you're seeing a lot of unusual glucose excursions, and especially following acute illness, you might see a decline in functional and cognitive abilities, and especially if you see an issue with polypharmacy. Care should always be individualized according to patient preference, functional status, comorbidities, life expectancy, and social support. In other words, target is based on how sick your patient is. Always include your family and caregivers, and the simplification of insulin has been tied to a reduction in hypoglycemia and reduced disease distress. Next slide. Overall, shared decision making with every patient is extremely useful, advised, and it's part of the guidelines. It does balance and facilitate the discussion with your patient, and as pharmacists, we're always speaking about recommendations for patients and medication recommendations. This is a way to really balance that discussion with your patient. Keep aware of clinical inertia. Stay abreast of new medications, risk to benefits. The handout that I provided is person-centered, outcomes-driven treatments. It's the newest addition to the ADA Compendia for 2020. It really does go into a very, very good way of addressing clinical inertia and what as pharmacists and clinicians can do to minimize it. Keep in mind food insecurity, social economics, health literacy, all very important to keep in the front of patient care, because any one of these issues and all of them will impact your patient's ability to self-manage and avoid unnecessary and preventable adverse effects. And will also determine what recommendations you give as far as pharmacologic regimen is concerned. Consider your support systems for your patients, include their caregivers and family, and again, be very familiar with what community resources you have around you so that you can have the solutions in the palm of your hand for your patients. Next slide. I want to thank you all for the opportunity. I want to put out a very special thanks to the National Center for Health and Public Housing, to Dr. Leon, Ms. Fide Sandoval, and Mr. Robert Burns. Thank you, Frank, for your time and contribution to the series and for your ongoing partnership with the profession of pharmacy. Truly appreciated. Really awesome presentation. And to all of you, thank you so much for participating and for the quality of care you deliver on a daily basis to all of your patients and to the profession of pharmacy. Thank you. Stay safe and stay connected.
Thank you, Terry. Thank you for your presentation. And I also want to thank Frank for the motivational interview piece. Teresita, thank you so much for the 4 sessions and everything that you covered for pharmacists. This has been a great learning collaborative. We have learned a lot on the role of pharmacists, and we are going to begin our Q&A session. So if you have any questions, please use the control panel and go to either the hand raise icon and your line will be unmuted, or if you would like to ask a question or type a question, use the question box on your control panel. So while we are waiting for some questions, I just want to announce that next Tuesday at 1 p.m. Eastern Time, we have a webinar on COVID-19 and the secondary traumatic stress identification, mitigation, and improving work satisfaction during the COVID-19 pandemic. Also on June 24th, we have another webinar on partnership opportunities for health centers, ambition centers, and public housing agencies. You are going to receive the slides with the registration link. You can also go to our website, www.nchpa.org, and you will find additional information on upcoming events. So, Fide, do we have any questions?
Not at the moment.
All right. I would like to ask a question, Frank, and this question is for you, Frank. How can you get, I mean, once you get people to change their behavior, how do you keep them motivated? I mean, it is in the clinical practice, you see patients who say, okay, I'm going to stop smoking, or I'm going to stop, you know, having unhealthy food, and you have them for 3-4 months, and all of a sudden they go back to the old habits again. So what is the key on how you can keep those patients motivated?
Well, first of all, I think you need to think about preventing the relapse. So you do that by anticipating whatever the point would be that would bring this person back to the old behavior. So, for example, if somebody has quit smoking, what we spend the few months after that is to start to examine what situations would you find tempting, what might be a reason for you to go back to smoking. So you start to look at what in their thinking might precipitate that relapse and then work to actually prevent it. So there's the 3 words I use are anticipate, plan, and rehearse. So you're actually anticipating what those situations might be. So let's say, for example, let's say somebody has been quit for 5 months, but they're going to a wedding, and they know most of their friends are going to be at the wedding, and they know they're going to be drinking, and they might see people smoking, and that might tempt them to go back. So the whole point is, now they know that, you can create a plan to prevent it, and then I actually rehearse it with them, either mentally or actually have them, do like a role play with me. So I think that's the key. I think it's actually unpacking what those situations are. So what might tempt somebody to go back to the diet that they used to have? Why would somebody stop exercising? What would be and so looking at that from that perspective, but also you use the word motivation. So it's constantly monitoring what that motivation is, reinforcing it, patting them on the back, giving them as much support as possible, creating a support system that is incorporating people that will keep them motivated. So one of the things we recommend with somebody quitting smoking is to start finding friends and start getting in activities that don't involve smoking, because in many cases that's their whole social circle are smokers. So it's looking at ways of getting support out in the community and within their family, friends, work that will keep the new behavior going.
Excellent. Thank you, Frank. Great response. Fide, any questions in the queue?
Yes, so we have one question, and the attendee wants to know, do you have any suggestions for encouraging patients, particularly patients who live alone or have physical disabilities, to engage in a regular exercise program?
Frank, is it okay if I answer this?
Yes, I was just going to say, go ahead, Terry.
So on one of my presentations, I turned you on to the International Council on Aging. If you go to their website, they have resources for you to tap into. You can find the appropriate program by going to that website. They have a way for you to search the type of program that you're looking for. So that would be my best advice to you. And that's what I was referring to in the presentation, is to know what your resources are, know where you can tap into and how you can select an appropriate resource for the patient. When it comes to seniors, I highly recommend that website. Your local YMCAs, they have Wise for Seniors. They do a really good job of promoting exercise programs and nutritional programs for your seniors. And they do a really good job of matching the program that's appropriate for them.
Thank you, Terry.
You're welcome.
Any questions, Irene?
Yes, there's one more. And this one says, do you have a technique to motivate patients who see that bowl of ice cream, bag of chips, or that little bottle of Coke as a highlight of their day? It's a confusing question. So maybe, I guess, they want to know a technique so that they don't go for that bowl of ice cream. You know, motivate patients to not go towards that.
You want to take this one, Frank?
Okay. Those all come down to cognitive techniques. So it's really teaching the person to be able to say something to themselves that will prevent that from happening. So to look at what the benefits are of not doing it, so but not stating it in a negative way. So it's saying to yourself, I want to be healthy. I'm happy with the person coming. You know, I can find other ways to have a highlight in my day. So it's right in that moment. It is what they say to themselves. Now, if you're looking at other behavioral things, it's simply don't. You know, I know this sounds very basic, but don't have the stuff in the house.
Exactly.
If it's not there, you can't eat it, and you're not likely to go somewhere just to get a bag of potato chips most of the time. So, you know, and if that is the case, then there are plenty of times that you can, if you make the decision to go buy the potato chips, you can stop at the door and say, okay, what's going on here? I'm happy that I'm not eating them. I'm not going to do it. Or if you're already in the car, or if you're at the doorway of the convenience store. So there are many spots where you can prevent that. The other thing is, you know, what's going on in the person's life that this literally is the highlight of their day. What else can we help them get into? Just like Terry was saying, can they join the Y? Can they get in a group? Can they start other activities? We realize that many of these people are very lonely and they don't have much else in their life. So I think a lot of it is prevention behaviorally, but if it's right in the moment, it's a cognitive intervention of just learning to say something like, I'm happy with who I am. I want to be healthy. You know, some kind of positive statement like that.
Thank you, Frank. Would you like to add anything, Terry?
Well, as I was hearing Frank's answer, I was recalling many of my patients, and I came across many patients like this, and they are very lonely, and they are, by circumstance, isolated. So I always found that if I asked the questions, what would you be willing to do? What would you be willing to change? A lot of times in my sessions with my patients, I would give them options as to, okay, well, if that bowl of ice cream is, you must have it right now, and obviously they're not going to change the behavior if they don't want to change the behavior, but what other solutions can I give them? So I would maybe ask them, would you be willing to maybe look at the serving size? Would you be willing to add a protein type food in order for that carb to impact your sugar levels as much. And perhaps that always got me into educating them on how our levels of glucose go up and how we can control that a bit. So yes, there's many circumstances and different situations that arise in patients. And this is it's a good question because it's one that we come across a lot. So I guess that using that ruler method, using open-ended questions, what are you willing to do? Maybe they're not willing to get rid of the ice cream right away, but they may be willing to reduce the serving size. They may be willing to, instead of having a pint of Coke, they may be willing to have 8 ounces of Coke. I mean, perhaps it's a very slow process. Like Frank iterated in his presentation, this is not something that's going to happen in a 20-minute encounter. So you tackle things one at a time and you try to do the best you can in opening up resources and ideas and helping the patient move along that change scale.
Thank you, Terry. And we are over the time, but you know, I am looking at the chat box and there is a very interesting question. So so this is going to be the last question, and if you have any additional question, please submit your question, and we are going to make sure that Terry or Frank get the questions, and you're going to get the response. But the question is, how do you motivate a patient to eat healthier who are in a rural area on a fixed income? The state's healthy foods are too expensive. I mean, and that's something really interesting. There are some of the patients that we work with, or the health centers have some patients in areas that are considered food deserts, and sometimes even if you have the motivational piece, you know, it's going to be difficult for them to find healthy food or healthier food. So what is your opinion on this, either Frank or Terry?
If I may, as you know, I worked in a medically underserved area, and food insecurity is huge, and it really is something that many times, unfortunately, we overlook. One of the resources that I gave was Feeding America. If you go to that site, you can find a food bank in the area. Again, and I stress, you need to find the resources in your community. In my community, there were supermarkets that had free dietitians that gave free classes to patients and introduced them to ways of eating healthy, if you will. I truly believe that it is a misconception for our patients to think that it is expensive to eat healthy. There are other options. Finding other resources in your area, churches, community centers, senior programs, all of these resources can help in these areas that are, as you call it, food deserts. So tapping into resources, going online, doing some research, knocking on some doors in your community is the best advice that I can give you.
I'd just like to throw in the idea of suggesting to them to start a garden. If they're in the rural area,
yes,
plant stuff. You can buy enough seeds for tomatoes, cucumbers, peppers, beans, all that stuff, and have it all summer long for probably $5. So, you know, if you find some kind of program that can do that, that's a great way to get people exercising a bit. And you know, when I grew up right outside of Pittsburgh in the suburb, every single one of our neighbors had a garden. We ate out of it all summer long. So that might be look into in this your particular area and see if there's any kind of resources to help people do that.
Yep. That's excellent, Frank, because in the area where I practice, they did actually do a community garden program. And it was something that was feasible. It was cheap, as you say, seeds are not expensive. And it really does get the patients out there doing a little bit of exercise with gardening. Totally great suggestion.
Excellent. Thank you so much, Terry, and thank you so much, Frank, for your responses. We're going to stop here. And again, if you have any additional questions, please submit your questions. And we are going to make sure that Frank and Terry receive those questions and you will get the answers back. So visit our website, nchph.org, where you can find additional information and publications on public housing residents and emerging issues affecting public housing residents. Also, please do not forget to complete this post survey after this webinar. And also join our mailing list, where you will find HRSA updates, information on funding opportunities, information on upcoming webinars, information on senior programs, and Medicare updates, and other resources and services. Next slide. These are our contact information. So if you have any questions, please address your questions to any of the staff members, or you can also call us at 703-812-8822. Thank you so much, Terry, for the Learning Collaborative series, and thank you so much, Frank, for the motivational interviewing piece of this webinar. Thank you, and have a great afternoon.
Thank you.
Thanks.